group, so hopefully we'll have some interaction as we go through. That's interaction. If someone was suggesting we also can have a roundtable panel, but since the room is set up this way, we'll go this and then can have more discussion. A couple of us were this morning as well, but it was first thing this morning, so. As you said, maybe we don't need it. Yeah. Is it better? We'll see. If it does one more time, then it's out. My name is Pramod Gaur, and this says. Oh, okay. I'm not lefty, but it's okay. We will try to work this way. Yeah, okay. This topic is very interesting to me because before, about 10 years ago, moving into telehealth space, I spent a good amount of time in point-of-care diagnostics, and it was the early days. And I want to acknowledge one of another colleague and mentor for me, Dr. Craig Lehman. He's the Dean of Health Sciences at Stony Brook, and he's going to be speaking tomorrow. But together with Craig and I, we started the journey of point of care. And now we are into the telehealth and wireless and patients. And I thought this is an interesting topic to see how can you deliver a patient-centric solution, whether it needs the blood test, does it need a vital signs, does it need a video consultation. So some of the speakers are going to be covering that aspect with you. Immediately after me, Dr. Suren Gupta, he spoke also yesterday. He has a beginning to think the same way, and he and I go a long way in terms of friendship. So what I'd like to do is to just kind of give you some background. I'm not going to go into a lot of detail, but to set the stage. So next slide, please. Now, I used this slide this morning, and I chose to put it again because around the world, there's a lot of pressure for healthcare and by governments, by consumers, care providers, sponsors. Consumers and care providers really are looking at access. Consumers want to know, how can I access the healthcare? In the United States, there are about 35 million uninsured coming in the pool soon. And in this country, about 65% of the population is living in rural areas, and again, a challenge for access. From the government and the sponsor, the insurance companies, obviously cost is a factor, but it's sort of combined with the quality. So CMS, which in the United States provide the insurance for elderly over 65, has for the last several years have created some metrics of quality indicators. And every hospital or physician who's seeing CMS insured patient must publish these quality metrics. And they're put on the website, and there's a scores of not very actively used by the consumer, but the hope is that over time it will create the choices for the people. People will be asking, okay, which choice I make, what are their results and stuff. So what we've done is, for my focus, I kind of combine all this, and I say there are just really two broad categories. One is access to healthcare, as we talked about, and then the other one is affordability. You know, you see a lot of solutions and stuff, you scale it up. My company is primarily a US-based company, but although it has some operation here in India, it has some in Philippines and in Northern Ireland, but I would say 95% of it is in the United States. And so the question is, how do we provide this patient-centric solution? Next slide. So we talked about that again. Those of you were this morning, I was thinking, and I said, I don't know about you. For me, sometimes I have to see it more than one time before it sinks in. So I decided to put this slide back in again. As an insurance provider for about 75 to 80 million U.S. citizens, nearly 1 in 5, our members have health care need for all of those what you see in the center. Some looking for wellness and prevention. Maybe they have some predisposed risk factors. Others who are in early stages and high blood pressure or diabetes or obesity. Oops, can you please put it back? I didn't realize it has timer. Then the behavioral health. And then after that, most of the telemedicine that is of substantial demonstration has been from acute care and post-acute care. When people were showing ROI, they are looking at people generally tend to be much sicker. They have had cardiovascular or diabetes for a number of years. Now they have complication. They are in the hospital. And there's what we call traditional telemedicine, where specialists and others, and there's been a lot of talk. That's the acute care phase. And you can expand that to share radiology films and others. That's the acute care phase. And we have our patient go through that as well. Then once the patient is released from the hospital is what we call post-acute care and rehabilitation. And again, someone had made a comment, I think Pankaj was saying that in the US, the government and the insurance companies are saying if the patient is discharged from the hospital and within 30 days is readmitted for the same illness, they will not provide the full reimbursement. But it's still by law they are required. They do have to provide the care. So post-acute rehab is big. And then the whole concept, as the population is living longer, what do you do in aging in place? People, given the choice, do not want to go to the nursing home, or at least delay going into the nursing home until they can. So that being the mix of the member, we'd like to call member rather than patient population. Now, when we're looking at the solution, we look at the key stakeholders. First, of course, is the patient. As someone was saying earlier, the psyche in this country is that if you can afford it, they'd rather go see a doctor and who can touch and so forth. So we have to educate. We have to show the evidence and the outcome are as good as you go seeing the patient. And it is increasingly a challenge, even in large metro areas, especially maybe some other part of the town, or especially if the rural, that's a whole day event. And many times 3 or 4 people are coming into bringing the patient. Then the caregiver and the community, again, we are talking about here is a non-paid caregiver, meaning family, friends, and sons and daughters. Those are the ones. They need a peace of mind. They just need to know when somebody is hospitalized, all the family members come to the hospital, now they are discharged. They would like to know what's happening. At least they can have some of information. And very often we ignore this factor. But remember, it's the health care we're trying to bring, and the caregiver is the integral part. Some have good support systems, some don't, and we're trying to assess that. On the provider side, this is a very interesting aspect. I have personally visited several busy doctor practices, and even in this country, one of my older brother, he's a primary care physician in 3rd tier District Ottawa in UP. And I see his practice, and any technology, anything you bring in, he's saying, okay, how does that fit into my workflow? As it is, I have more patients than I can see it. You tell me how it's going to help me through. And not only just sell me the technology, at least for 6 months or a year, help implement. Then maybe some will want to take on. But since this is a new way of doing it, they have no time if the technology is not working, if the outcome is not. So that's what the provider side. And as the access is going to become available, the question comes, how do you fit into the physician workload? They are not used to getting 2 or 3 readings every day for blood pressure and things. And there are some issues about liability. Does that physician is liable because they have the data and they did not react it? And certainly malpractice insurance is a major issue in the United States, but also here there is some aspect of that. And then we talked about the payer. You heard the minister pilot saying this morning, I think, was that the government is increasing per GDP from 1% to 2.5%. That's encouraging, but they don't want to have it the same way. They're saying, if I'm increasing, show me where the efficiency is. Show me how you're going to see and provide the care with these quality indicators, but at lower cost per patient. So this is the kind of key stakeholders that I thought is pertinent. So next slide. And now I'm just touching it, and others will talk more. In the telehealth, telemedicine space, we primarily focus on video conferencing, maybe taking some vital signs, stethoscope, blood pressure, pulse ox, and so forth. But if you holistically, 360-degree, you're focused on the patient, then you have to look at what other things you can provide to the patient from remotely. And point-of-care diagnostics, whether it is done in a telemedicine setting, in a satellite office, or it's done from home, that's a very important element. I don't think it has really been talked about combining, but I know Alair, who Dr. Gupta is going to speak, he's already thinking in that direction, and we are as well, because when you're trying to provide a sustainable, large scale, you can't just say, well, just take out this portion of it, then you do this, go back to the same place. You need to look at 360 view of that patient care. So you have several of these devices now available. Alair has another one for cholesterol, whole blood lipids, and PTINR, and hemoglobin A1C, as we said yesterday, for a person with type 2 diabetes. Once they have finished the diagnosis, and even if they are giving them, most of the time, if it's not controlled, they give tablet oral medication. Once it's stabilized, once 2 to 3 months, 4 months, hemoglobin, just average glycation is really what is needed. PTINR, this is for people who are in blood thinners, those who have some stent and other cardiovascular devices, and they need to be, again, in the beginning, there's very intense titration, and then it's done only infrequently. And the concept here is that many of these, the point-of-care devices, need not to be in the patient's home. They can be in the community because they are used less frequently. But if that is required to assess the patient condition, we need to look at. In the bottom, what you're looking at is the traditional blood pressure, spirometers, glucose, and scale. Most of them are Bluetooth enabled. If you want to aggregate, there are some companies have dedicated medical device to aggregate. Others can use the PC with the Bluetooth, or even some of the smartphone. All that is doing is a software that's aggregating and then uploading to the patient's health record. So I think this probably is the last slide I have. Oh, there's one more. So what happened is that once you are focused on the patient, you need to look at what you do. And again, if you are interested in 360 view of the patient, we have to look at all different things that patient is doing. One of the things my company does is they have kind of divided into 3 areas. Who I am, again, this is the information about personal health record, person, who they are. What I do, what kind of testing or how I'm engaged to my chronic disease. And this is a new concept, what do I get? There's some pilot work is going on in giving some kind of discount. Some employers are giving reduction in their health insurance premium. Others are giving incentive different way. And my company is also trying different ways. They were one of the first ones to have wellness credit for annual health insurance fees. And now, 2-3 years into it, they are constantly looking other ways. What happens is that at the time, we typically in the US, once a year you are enrolling for your health care. They feel good that they're getting this discount, but then as the year goes through, that becomes less interesting. So we're saying is rather than everyone getting the dollars, maybe we should experiment, offer some personalized coaching for wellness, or some even give them the exercise bike or other equipment. These are some different ideas we're doing in one GAT. And there are also all kind of opportunities that one can have with the drug companies, the pharmaceutical distributors who can have coupons or some things like that. So it set the stage. We are still exploring in terms of what do I get. But this is how it is done for every single member that is going through. And now here's the scale part come into it. So as we look at, we cannot develop everything ourselves. But this is something we insist that there should be one unified record. And as we do the ecosystem partners, there's data, their information should be deposited in personal health record that is easily accessible. They can give rights to their loved one, as we talked about, caregivers and others. So that's kind of where we see this going in a larger scale and combining all the intervention that are needed. We also have module for pharmacy, so medication pickup, because we as an insurance company, usually it comes afterwards, the data, but those of you familiar with the US system, when we go to the pharmacy, just like the credit card transaction, within 30 seconds, there's a validation that does this patient has coverage and what their plan is, and then pharmacist said, here's your $15 copay, or this particular brand is not in the formulary, you have to pay $35 and so forth. So that's another area we're working with pharmacy chains and trying to say, okay, how can we bring all this information together? So I'm going to stop here.